thanks for the invitation to come here. I get lots and lots of invitations to go and speak to places, but I think this issue about, well, there are two things about this conference I think are particularly important for me. One of them is the whole issue about patient experience and about how we make it a reality as opposed to talking about it. And the second issue is about long-term conditions and about the points particularly Tahir made there about the importance, the significance of long-term conditions, a whole group of in fact the largest group of our patients that we treat, and the significance of better treating that group of patients for the future of the NHS. And that was the thing that made me come along, and so thanks very much for the opportunity. And I have been able to sit at the back and listen to a whole series of things. I don't know about you've learned. I've learned a whole series of things this morning. I've learned about the frustrations of Jenny and her work with PCTs that we can certainly take back and think about how we can give people the incentives more and the framework to make that happen. I've learnt about some really interesting stuff around arthritis care and the kind of expert patient work that needs to be done. It seems to me this is a vital in educating and supporting and helping patients to engage, be involved. I use the term engagement in the sense of getting married rather than engaging someone in a battle. To do that, but how you need to educate and support patients to make that happen. I've learned with something that reinforced in a sense something that I knew about the progress that's being made around Mason and Tunbridge Wells, and I think some interesting lessons in all of that for us all, which I'll refer to in a while. And I've seen some mind maps in a way I've never seen them quite before. But what I also seen is how actually getting involved in patient experience doesn't have to be a long and complex and bureaucratic exercise. It's simply about a team that are motivated to make it happen, who talk to their patients, who reflect on their practice, and then put it into action straight away, which doesn't take hours, doesn't take years, doesn't take massive bureaucracy. It just takes commitment and involvement, and I think that's fantastic. And when I think about patient experience involvement in particular, it seems to me my contention is that it is more important now than it has ever been. And in fact, I judge, and I guess shared by many of you, and I suspect many outside, that it is the most critical, the mission critical thing for us as we take the NHS forward into the future. We know that empowered, involved patients do better. We know that. All the evidence, the research shows us that is the case. We know that patient involvement and listening to patients avoids the kinds of things that Mason and Tunbridge Wells went through. If you look at the big three problems, issues that we've had that made national significance, Stoke Mandeville, Mid Staffordshire, and Mason and Tunbridge Wells, there are a whole series of things that are consistent about them. But the thing that's most consistent about them is that the patients groups and their supporters were telling these organisations there were issues long before the management and substantial proportion of the clinical staff were able to respond to them. So listening to your patients avoids us getting into serious difficulties. And the third thing, and the thing I'm going to talk about a little bit, is that, this came out, I had a breakfast meeting earlier this week with a whole series of patient groups about all of this. Engaging and involving patients in their own care and in their own services is actually more productive. It actually saves money, reduces cost, and improves quality. So all of those things, it seems to me, are absolutely critical as we take the NHS forward into its next phase of development. And if you think, the NHS is, we're not at the destination by any stretch of the imagination, and I think there's been a whole series of issues been raised about our shortcomings in this conference that show we've got a long way to go. But we have started on a journey which is really, I think, significant, both for us as people who work in the NHS, but also our patients as well. The first bit of that journey was all about building capacity, having more of almost anything you can imagine, more staff, more hospitals, we grew the size of the NHS during that period by a third, a massive growth in healthcare delivery in this country, not seen in the past, and looking at the future, it's unlikely to be seen in the future either, but a big spurt in our growth. And the way we delivered change, our focus on change was big national government targets, which can be really significant in the sense of if you're a long way back in something, they can give the NHS that kind of spurt forward that it needs some time to really tackle some of those issues. They're very good for those, and they're very good for a short space of time, and they're very good if there are only a few of them. If there are lots of them, I think you start to have real problems. In a sense, we're learning that lesson now and trying to move away from that as the way forward. So an important lesson, I think, for us to learn. But the other thing is they're not very good for things like patient experience and wrapping services around the individual needs of patients. I guess there's nothing more toe curling, I guess, for a clinician and the whole set of you in the room, or even people who work in the NHS generally, to be told by the Department of Health to make your services more patient-centred. You know, if someone said that to me, I'd be pretty irritated. But it doesn't work. It doesn't give you that kind of help and support that you need to make a reality of that. Which kind of brought me to the second stage of our development in NHS, which was all about the kind of levers of reform. You know, how you make all of this sort of things. So on the one hand, it might be about patient and public involvement, it might be payment by results, it might be the tariff, it might be foundation trust. All of these things are all designed to help us, not hinder us or stand in our way, but help us deliver more devolved care, more wrapped around the individual needs of patients. And one of the issues, I think, that we certainly as NHS managers have kind of forgot, particularly I think about 4 or 5 years ago, is that these are levers to help us. They are not ends in themselves. People get terribly excited about some of these levers, but actually it's about what they do, how they can improve services for our patients, which is significant, not them in themselves. Which sort of brings me to the kind of the current phase of the development of the NHS, which came out of the work that Lord Darcy did, the next stage review. Because one of the things I think that we got ourselves into as an NHS is we kind of lost, certainly at a senior level and particularly at a national level, I think, we sort of lost the reason why we were there. We got so excited about the reforms and the changes and all of those sorts of things that actually we started to lose sight of what we were there. And that showed itself most obviously by the disconnect between managers and clinicians and the public. And you could see that in all sorts of ways. So the next stage review was really important to us, not just because it started to focus us as a system on what really we're there for, which is improve the health of the population, improve services to our patients, but also the way we did it. The next stage review was not a small group of people sat in a room in Richmond House thinking up clever thoughts to inflict on the NHS as a whole. It genuinely was about engaging with people and working with people and thinking about how we might take the things forward, which I think we all learned huge lessons from, and something we can't lose as we go into more troubled times. And central to all of that work was two things really. One of them was to say that actually there isn't a patient interest over here and a clinician interest over here. They're both mutually supporting. And the idea that in somehow you can force clinicians to do things or you can force patients to do things, simply not true. The way you get real change is involvement of patients and clinicians together. That's the way you really make it happen. But as part of that, you need to give patients more clout, because the difference in terms of power and responsibility and information is so great between clinicians and patients. There are extra things you need to do to support patients and, in a sense, give them more clout. So that was the first thing.